Hello, good morning everyone. Today I'm going to take class on eyelid disorders. So, so basically, we need to know about the eyelid, the main anatomy behind it. So, an eyelid is a thin, you can say, fold of skin that covers and protects an eye basically. And the main muscles which is involved in the levator palpebrae superioris muscles that retracts the eyelid, exposing the cornea to outside. So that basically it's important to give vision for that. So the human eyelid features a row of eyelashes along the eyelid margin, which serve to highlighten the protection of the eye from dust and foreign debris, as well as perspiration, right? So this is a picture showing the glands, showing the upper eyelid, lower eyelid, showing the lower lacrimal canal, lower lacrimal punctum, then we have the lacrimal gland, we have the eyebrows, we have the sac, we have the nasorectal duct. So this is just to give an idea. So basically, these are the short curved hair, the eyelashes situated on their free edges. The layers of the tissue which form the eyelids are basically a thin covering of the skin, a thin sheet of areolar tissue, and then we have the three muscles which play a very important role. So these are orbicularis oculi, levator palpebrae superioris, and Mueller's muscle. A thin sheet of dense connective tissue, tarsal plate, that is larger in the upper than in the lower eyelid. So this supports the other structures as well. And we have a lining of the palpebral conjunctiva. Okay, so this is the basic thing. Three muscles are there. So we have the LPS, we have the orbicularis oculi, we have the Mueller's muscle. So you need to know that. So the three muscles important in this eyelid. So this is the thing. So now we come to the lid margin. So the lid margin is basically it is about 2 mm broad, and it is divided into two parts by the punctum, right? So divided into the rounded anterior and the sharp posterior borders by the gray line, right? So the gray line is very important. The gray line is important in operations where the lid is split, as it indicates the position of the loose fibrous tissue between the orbicularis muscle and tarsus. So basically these eyelashes originate anterior to the gray line, and ducts of the Meibomian glands are located posterior to the gray line. So you need to know this. So the Meibomian glands are basically located posterior to this gray line, and gray line is very important in the OT procedures where the lid is split, as it indicates the position of the loose fibrous tissue between the orbicularis muscles and the tarsus, right? So the eyelashes originate from anterior to the gray line. We come to the glands of the eyelid. So first we come to the Meibomian gland, which is also known as the tarsal glands. So the Meibomian glands are basically the modified sebaceous glands. So they are about 20 to 30 in number in the tarsal plate, and they are directed vertically and open the lid margin. So therefore a vertical incision is given while giving the incision in the chalazion. So this is also an important question for your viva. The external always ask if you are given a short case of chalazion. So they always ask how the incision will be given in chalazion. So you need to remember that the incision is always given vertically, and this is the reason to give the incision vertically, because we have different glands, so they are arranged vertically. So we need to give a vertical incision so that we can protect those glands, right? Otherwise it may lead to other issues, right? Then we have the Zeiss glands. So these are also modified sebaceous glands attached to the hair follicles. Then we have the mole glands. So these are the modified sweat glands which open in the hair follicles or directly in the lid margin. Then we have the accessory lacrimal glands of Wolfram. So these are structure of the upper eyelid present near the upper border of the tarsal plate. And then we have the palpebral fissure. So the palpebral fissure is basically space between the two lids when the eye is open. So this is known as palpebral fissure or palpebral aperture. So this is basically a space between the two eyelids when the eye is open, right? So we have the Zeiss gland, we have the mole gland, and we have the accessory lacrimal glands of the Wolfram. So the Zeiss gland is also a sebaceous gland. Then we have the mole, which is a modified sweat gland, and we have the lacrimal gland of Wolfram. So this is again present near the upper border of the tarsal plate. Right? So we have the Meibomian glands, we have the Zeiss with the mole, we have the accessory lacrimal gland of the Wolfram. Okay. Then we come to the disorders of the lid, right? So first we need to know is about blepharitis, right? Okay, so blepharitis is the most common ocular conditions, basically characterized by inflammation, scaling, redness, crusting of the eyelid. So these condition may also cause burning, itching, or which introducing sometimes foreign objects also. So, although blepharitis is not a sight threatening, but it can lead to permanent, what we call alterations of the eyelid margin, right? So, if I say the overall etiology behind this is basically as a result of the bacteria, right? So, blepharitis is a chronic inflammation of the lid margins. The etiology, it follows chronic conjunctivitis due to staphylococcus in basically children usually who are living in poor hygienic conditions and all. And then we have other conditions which may give rise to blepharitis. So this can be infectious or non-infectious sometimes, but the most common is bacterial infections or allergies. So there are different variations of blepharitis that can be classified as seborrheic, staphylococcal, mixed. We have the posterior or the parasitic. So the parasites also play important role in causing blepharitis. Okay, so this is the blepharitis. It's basically chronic inflammation of the lid margins. So just a minute, some issue. Right, so okay, so now we come to the types. The types is, first we have the squamous blepharitis, right? So it is basically due to an abnormal metabolism in seborrhea, so associated with the seborrhea of the scalp, brows, ears, and is basically non-ulcerative. So there are numerous white colored small scales that accumulate among the eyelashes. So the eyelashes fall out readily but are replaced without distortion. So on removal of the scales, the underlying surface is basically a bit hyperemic. So the scales are greasy with less marked redness of the lid margin. Okay, so this you need to know the types. Okay, so then the symptoms of squamous blepharitis. So the patient usually complain of deposition of the whitish material, soft scales at the lid margin, associated with the mild discomfort, irritation, occasional watering, and a history of falling of the eyelashes. Right. So these are the symptoms. So basically a deposition of the whitish material at the lid margin. Right. So the signs include is basically you have the accumulation of the white dandruff like particle like scales is seen on the lid margin among the lashes. So on removing the scales, as I told you, the underlying surface is found to be hyperemic and greasy, but no ulcers. The lashes falls out easily but are usually replaced quickly without distortion. The lid margin is thickened and sharp posterior border tends to be rounded, leading to epiphora in long-standing cases. So the signs basically which you need to know is like there is the accumulation of the white dandruff-like scales. Then you have the hyperemia. Then you have epiphora in some cases only. Next we have is the ulcerative blepharitis. So it is an infective condition. So the yellow crest glue the lashes together. So we have the sticking of the lashes, the matting which we call, right, the matting of the eyelashes together. So on removing the crust, there are small ulcers seen around the bases of the lashes. So these ulcers, it usually bleeds. So this is the difference between the ulcerative and the previous one. So the lashes fall out, being replaced by the misdirected lashes. Usually ulcerative is more serious due to the involvement of the base of the hair follicles, and redness of the lid margins with scale is seen. Permanent scarring can result. So these are the differences between the ulcerative and the squamous blepharitis, right? So in ulcerative, we have the matting of the lashes, we have the bleeding, we have the ulcers, we have the redness, and it can lead to permanent scarring also, right? So these are the differences between the ulcerative and the squamous blepharitis. So you need to know the difference between the two. You need to know the definition, you need to know the symptoms and signs, right? So yeah, so these are the differences between the squamous blepharitis and the ulcerative blepharitis. So first we come to the clinical features in scales. So scales are usually white, fine and dry in squamous blepharitis, but we see yellowing, coarse and sticky, which we call the matting, is usually seen in the cases of ulcerative blepharitis. Ulceration is usually absent in squamous blepharitis, but it is present in ulcerative blepharitis. Bleeding is usually absent in squamous, but present in ulcerative. Loss of eyelashes is few and temporary, but in ulcerative it can be permanent, right? Course is usually mild, but in ulcerative it is progressive. Complications are again, it's mild, occasional, but in ulcerative is usually more serious. Ulcerative blepharitis is a more serious condition as compared to the squamous blepharitis, right? So these are the differences which you need to know, right? So this is again, it's based on the location: anterior blepharitis, posterior blepharitis, and mixed. So these are the types, which is based on the location. So when we come to the anterior blepharitis, it usually refers to the inflammation mainly centered around the skin, lashes, and follicles. But whereas posterior variant involves the Meibomian gland, the orifice, Meibomian gland's tarsal plate, and blepharoconjunctival junction, right? And in mixed, it is a combination of these two. When you come to the signs, it's like, it's more of matting of lashes, discharge, uh, hard scales, and these all are related to the anterior blepharitis. But in posterior, it is not as much as anterior, and the mixed one is like it is combination of both the types. So these are the differences, like, based on the locations. So we have the three types: the anterior, posterior, and mixed. Clinical pictures. We come to the symptoms. So the symptoms basically involved, as I told you, is redness, soreness, lacrimation, photophobia, irritation, burning, itching. So these are the main symptoms. Signs: we have the scales on the lid margins, we have the eyelid ulceration and redness, right? So in the picture, as you can see, the eyelid being swollen and redness is there, scaly scabs you can see. So this is basically a picture of blepharitis, right? Now we come to the treatment part. So depending upon the severity of the disease, one or multiple therapeutic treatments are utilized. Pharmacological agents and mechanical treatments are often required, such as lid hygiene, warm compresses, and antibiotics. So lid hygiene is an essential part of the treatment and usually done at least twice a day, right? The crust removal and lid margin cleaning with the help of cotton buds dipped in dilute baby shampoo or a solution of 3% sodium bicarbonate. So this is very important in cases of blepharitis. You need to do the lid hygiene. It is very important in these cases, right? Warm compresses for at least 5 to 10 minutes to soften the crust. So that can increase the oil production and melt the oil in the Meibomian glands. So these are very important warm compresses, which are universally accepted as a therapeutic management modality, right? However, there is no universal recommendation regarding how to apply warm compresses, but still warm compresses 5 to 10 minutes it is recommended. Okay, so we have the lid hygiene, we have the warm compresses, then the antibiotic therapy. So several types of topical antibiotics, drops and ointments are usually recommended, but some of the commonly used are, azithromycin. So that is usually prescribed 1 drop at bedtime for 1 week or more. Then we have the bactricin ophthalmic ointment. So these are, usually applied to the base of the eyelids 1 or more times, usually 2 times a day for at least a week. Then we have the erythromycin ointment, so that is also applied at the base of the eyelids 1 or more times, right? And again for a week. Then we have the ciprofloxacin ointment, eye drop, that is 4 times a day for a week. So these are the treatment. So basically, we have the ointment called Occupol. So you can give that also, and tell the patient to just pull the lower lid, apply it, and just go off to sleep, because the ointments are usually better than the drop, because it stays in the eyes for a longer period of time. So that's why, we tell the patient to, apply ointment as compared to drops. Drops are beneficial, but ointment is the best part. Okay. If it is associated with allergic conjunctivitis, then we can give a combination of antibiotic and steroids. So we have the Zoxan D eye drop 4 times a day. Then we have the phenolic eye suspension, that is basically 3 times a day, that can be prescribed. So these are the other treatments, right? Now next we come is the stye. So I hope you all know about the stye. The stye is basically infection of one of the small oil producing glands, right? So that is usually caused by bacteria that are normally found along the eyelids. So a stye can occur on either of the lids, that is the upper or the lower. So basically there are 2 types of stye. the internal and external hordeolum. The internal hordeolum, which is known as stye, is a bacterial infection of basically Meibomian glands inside the eyelids. So the internal stye tends to be more severe and occur at a less often than the external hordeolum, right? So the external hordeolum is a bacterial infection of the glands of the eyes, of the glands of the mole inside the eyelid. So you need to know the difference between the internal and the external hordeolum, right? So one is the infection of the Meibomian glands and the one is the infection of the size gland. So these type of stye is more superficial and tend to heal more readily, right? Signs and symptoms of stye. So stye is basically a well-defined lump or bump on either upper or the lower lid, localized swelling of the eyelid. You will have pain in the eyelid, and it is usually sensitive to touch, redness of the affected eyelid, crusting, burning. Eyelid may appear droopy. So the mucus or the watery discharge in the eye, irritation of the eye. So these are the possible signs and symptoms of stye. I hope you all have seen a patient of stye, right? So these are the thing how it looks like. So this is the picture. You can see a stye on the lower lid. You can see the chalazion, which will come to later. So it looks like a red tender swollen bump on the edge of the eyelid. So you may be able to see the infected gland on the eyelid, right? So infection may quickly become quite large and painful. So the eyes are teary. So this is one of the basic difference between stye and the chalazion. Stye is usually painful and the chalazion is painless, right? So you need to remember that. Then we come to the external hordeolum. So external hordeolum, as I told you, it is basically acute suppurative inflammation of the lash follicle and associated with the glands of Zeiss or mole. Okay, so you need to know this. Etiology behind is like age. It is more common in children and the young adults, and in patients which who are having more eye strain due to the muscle imbalance or the refractive errors. So any patient which comes to you with a stye and it's usually repeated, so then we need to consider the causes. So the possible causes could be eye strain or it could be a refractive errors. So refractive errors, though refractive errors are not done or checked during the infection because it changes the shape of the cornea. So we usually call the patient after the stye is treated, right? So these are the things which you need to know. Then we have the rubbing of the eyes or the filling of the lids and the nose. Chronic blepharitis and diabetes mellitus are usually occur associated with the recurrent stye. So these are again the possible causes. Metabolic factors, more intake of carbohydrates and alcohol can also lead to these kind of infections. And the main organism, as you know, is Staphylococcus. Clinical features, symptoms include acute pain associated with the swelling of the lid, watering and photophobia. Signs which you can say that there are stage of cellulitis, so that is basically characterized by localized firm, red, tender swelling at the lid margin associated with the marked edema. Usually there is one stye, but occasionally there can be multiple. So stage of abscess formation is characterized by visible pus point on the lid margin in relation to the affected cilia. So there is a stage of cellulitis, a stage of abscess formation you need to know. Then we come to the treatment. So treatment is again hot compresses 2 to 3 times a day, which are very useful, especially when the stye is in the cellulitis stage, right? Then we have the evacuation of the pus should be done by piloting the involved cilia when the pus point is formed, right? So then we have the surgical incision is required really for the large abscess. Antibiotic eye drops, again it can be given eye drops and eye ointment, so this should be applied to control the infection. So we have the hot compresses, we have the evacuation of the pus, we have the surgical incision, and medically you can treat like antibiotic eye drops or ointment and hot compresses. So you can call the patient after a week if the stye has increased and it has become a large abscess. Then you need to surgical incisions and remove it, right? The non-pharmacological, we have the warm compressors. As I told you, we have the epilation, we have the incision and coarctation. Right. Okay, so these are again the treatment part. So you don't need to go in detail. Only the thing is, we have the ointments, we have the drops, as I told you. So this is basically neomycin sulfate polymyxin B. So this I was talking about. So these are the composition of the occupal ointment. So when it's combined with occupal D, so that means it's neomycin plus polymyxin B plus dexamethasone. So this is usually applied 2 times a day for a week. Okay, now we come to the internal hordeolum. So internal hordeolum is basically a suppurative inflammation of the Meibomian gland associated with blockage of the duct. So the etiology again we come is basically a staphylococcal infection of the Meibomian gland or due to a secondary infection of Chalazion, right? So the clinical features are basically, again, it includes acute pain associated with the swelling of the lid, mild watering and photophobia. So the symptoms are similar to hordeolum externum except that the pain is more intense due to the swelling being embedded deeply in the dense fiber tissue. Signs is usually a localized form, red tender swelling associated with marked edema. On examination, it can be differentiated from hordeolum externum. That the point of maximum tenderness and swelling is away from the lid margin, and that the pus usually points on the tarsal conjunctiva and not on the root of the cilia. So this is the basic difference between the hordeolum externum and internum. Treatment is usually similar to the hordeolum externum except that the pus is formed. It should be drained by a vertical incision from the tarsal conjunctiva. Okay, then we have this Chalazion, so which is also known as a Meibomian cyst. So it is basically a chronic lipogranulomatous inflammatory lesion caused by a blockage of Meibomian gland orifices and stagnation of sebaceous secretion. So it is basically a lipogranulomatous inflammatory condition, right? So the patient with acne, rosacea, seborrheic dermatitis are at increased risk of Chalazion formation, which can be multiple or recurrent. So if it is recurrent, one can think of sebaceous gland carcinoma, but not usually seen. So the etiology is basically due to chronic irritation caused by an organism of low virulence. The glandular tissue is replaced by the granulation tissue containing giant cell predominantly. It is often multiple in numbers occurring in crops. It is more common in adults than in children. So these are the things. Clinical features of Chalazion is, when we come to the symptoms. So the symptoms is usually there is no pain unless the Chalazion is secondarily infected, right? So Chalazion and stye, you need to remember Chalazion are usually painless, whereas styes are painful. So these are the things. Okay, and there is disfigurement due to the presence of swelling in the lid. So this is again, and it may be single or multiple in number, right? When you come to the signs are usually a small, non-tender, hard swelling in the lid, slightly away from the lid margin is seen. Whereas if you see stye, it is basically on the lid margin, so this is slightly away from the lid margin. This is again a differentiating point between a stye and a Chalazion. And there are no signs of acute inflammation. On everting the lid, The conjunctiva over the swelling is red and purple. So this here, the conjunctiva, you can see it is grey in color in later stages. It may be yellow and secondarily infected by pyogenic organisms. So the chalazion may occur following a stye also, or from hardened oils blocking the glands. So the blocked glands is usually the Meibomian gland, but can also be the gland of size 2. A stye and cellulitis may appear similar. Stye is usually most sudden onset, painful, and occurs at the edges. So as I told you, the chalazion is a little bit away from the edges, lid margin. So these are the differentiating points between the chalazion and a stye. Right. So clinical features, if I tell you, so it's basically painless swelling, eyelid tenderness, increased tearing, heaviness of the eyes, redness of the conjunctiva. So these are the signs and symptoms. So this you can see is basically this is a normal, and this is basically showing the chalazion. Okay, now the management part. So the management part basically includes non-pharmacological, pharmacological, and surgery. Right. So it's 3 parts. So in non-pharmacological management, we have the warm compresses for 5 to 10 minutes daily for 1 or 2 weeks, and epilation of the involved eyelashes, and again incision and curettage if it does not disappear with other treatments. Right. Pharmacological, then again we have the ointments, we have the drops. Right. It can be combined with the steroids like dexamethasone or hydrocortisone. It depends, to give 2 to 3 times a day for a week or so. Right. So we again have the ointments, we have the drops, we have the warm compresses. Right. So these are the treatment part, and if not treated with the drops and the ointments, so we need to do the chalazion, incision, and curettage. So this is again done with the chalazion clamp. I hope you all know. So we just invert the eyelid, put a vertical incision, scoop out all the cheesy material until and unless you feel the gritty sensation is usually felt. Right. So that is a surgical thing. If it is not treated medically, then the last option is we remove it surgically. Right. So again, treatment plan, I'll just come. Topical antibiotic drops or ointments are usually given, but the choices are again, as I've told you, chloramphenicol or fusidic acid. So they are usually used for initial acute infection. Right. Then again, I have told you the warm compresses. Then but if they continue to enlarge or fail to settle within a few weeks, or if I may say so months, the smaller incision may be injected with corticosteroids. So these can be removed surgically. Right. So these are the treatment part of chalazion. So yeah, and last, if I come to the complications, like if it is left untreated or if it is not getting resolved within a few time period. So a large chalazion, they cause astigmatism. And why astigmatism is caused? The reason behind it is because it puts a pressure on the cornea. So the cornea, the shape of the cornea changes, and you have the refractive errors. So the large chalazion can cause astigmatism. So these is one of the important complications. Right. So, and again, we have the complications of corticosteroid injections. So which includes hypopigmentation and fat atrophy, which is less likely to occur in conjunctival approach of the injection. So we have the hypopigmentation, we have the fat atrophy, we have astigmatism. right? And reshaping of the cornea again, it weakens the structure, the post operation, and people can be left predisposed to deformation of the cornea from small chalazion. So these are the complications. So astigmatism is a very important thing because it changes the shapes of the cornea, right? So these are the complications of chalazion. So I hope you all today at least have got an idea about the stye. First we have the blepharitis, the types of blepharitis, the symptoms, signs of blepharitis. Then we have the stye, difference between the internal nodular and external nodular, and then we have the chalazion. So you need to know the difference between the chalazion also and the stye also to differentiate, because these are things which can come as a short case for you all. So these are the basic questions which an examiner asks, right? And treatment, as you can see, the treatment is basically same in all the cases. We have the same antibiotics, we have the same ointment. Everything is same. The warm compresses is usually applied in all the cases. So these are the things. So anyway, I think for today I'll just stop here. Next week I'll just let you know on what topic I'll take the class, right? So thank you so much. Good day all of you.